you've got a good point there. And I think there's traditionally there's been a wrap to cover weight loss or weight management wrapped up with a disease, and mostly diabetes. I mean, so I think, and I can, broad strokes and not, everybody can sort of say, well, not all the time. So I think those are sort of my disclaimers. I think it's much easier for a health plan to rely upon evidence base, and if it turns into a mandate for A or B, I think that allows some security, if you will. And in the sense, what I mean is that we struggled with. In Colorado, when we rolled out DPP, it was before the T code for a specific DPP program, but I wanted to get it done, and so we did it sort of creatively. And unfortunately, what potentially can happen is that, and so in a risk, that's what insurance is sort of a risk piece. You want to make sure that what you're paying for, or that your members that you're essentially responsible for, are going to programs that are legit, and that clinicians are working for essentially for the best of the patient, and not selling products or the strip center weight loss, which potentially can happen. So I think there's some need to have assurances and guardrails, and exactly what the program is that you want to sort of put out there, that you're into some. So it's a sort of a slice to that. I think what we've talked about earlier about what kinds of evidence. Now, of course, we cover bariatric surgery with certain criteria, and if that's met. So I think there's a lot of layers to that. I know it's a little murky, because I think it is that way.
I guess my one other comment before we get to the other question is that some plans were covering it prior to the Affordable Care Act, and so. But it's very, very variable, I think.
I would just quickly say the law was made for a reason, because you needed the law. I mean, people don't cover things unless you either have to or people demand it.
So I'll just add wearing my political hat, not my clinical hat, for a second. So it looks like, of course, this changes every day, every hour, every tweet, but. It appears the ACA will be repealed through reconciliation, and what the reconciliation process does is it just affects those pieces of the Affordable Care Act that have some sort of budget consequence, like a tax or a mandate or subsidies. The Section 2713 of the Affordable Care Act, which focuses on coverage of preventive services like USPSTF A's and B's, and all private plans have to cover them without cost sharing, that will likely not be repealed through reconciliation. That being said, I think there is going to be some uncertainty in the market, particularly the marketplace plans. Don talked about these essential health benefits. The new HHS secretary could, through regulation, try to loosen sort of coverage of all 10 of the essential health benefits. Medicaid expansion states, they're also supposed to cover all USPSTF recommended services A and B without cost sharing, so there's a big unknown there. I think just in terms of ACA and health reform, the other 2 points I'll make, I think a lot of people are now concerned about or thinking about, depending on where you sit, what if Medicaid goes to state block grants, and what does that do in terms of less dollars going into the Medicaid program? Does it offer innovation opportunities at the state level to perhaps tackle some of these things, or since the pie is smaller, will it just reduce coverage? And then I'll just sort of talk about CMMI for a second, just because sort of you asked about ECA. Our perspective right now is that it appears that the new administration will want to keep CMMI, and there are a lot of, as Dershowitz mentioned, there are about 50 models ongoing right now, DPP being one. Good part about DPP is it's baked into the fee schedule, and it does have sort of, I think some sort of bipartisan support. So I think things coming out of the Innovation Center, probably more protective. Commercial plans, they're still sort of on the hook. I think when you get to Marketplace and Medicaid, then you start to worry that some of these political decisions may have ramifications to obesity coverage, for example.
Great answers, and just making the point, it's not a simple
answer. So, one last question.
Hi, Katie Schmitz, Penn State. The way that CMS makes decisions clearly changes over time. And so I'll just remind us that actually coverage for cardiac rehabilitation happened before we had evidence that there was a benefit for recurrence of MI. In fact, it was approved in 1982 upon a very large political push on the part of the American College of Sports Medicine and the American Heart Association, the American College of Cardiology coming to CMS, and the primary outcome that they were really interested in, and it was based primarily on studies that were done in Scandinavia, was about return to work and the need for the men who were having these heart attacks to get up out of bed and get back to work. And that it was not actually until 1988, 6 years after it was approved by CMS, that we had not even a randomized controlled trial. In fact, there has never been a single randomized controlled trial that has shown that exercise or cardiac rehabilitation will prevent an MI. It was actually a meta-analysis that showed that. We were never able to show in a single trial. So the idea that we need trials and a single trial, and that that the Be Well trial needs to be positive for us to be able to get coverage for this, is holding things to a very different standard. The other thing that I want to ask that I think could be a comment back from you all is, what I said was that cardiac rehabilitation was approved on the basis of getting people back to work. Is that a basis that we could approach for cancer rehabilitation?
Sure. So I get to. So, yes, I think the point that standards change over time is a good point, an obvious point. Standards change. So I'd say there are two ways to. I'll just be really concrete about it. There's only a limited number of ways you get new things paid for. So you can do a new coverage decision, what's called an NCD, or you can do an LCD, which is a local coverage decision. NCDs are national coverage determinations that are done, very complicated, politically fraught. In general, the bar is pretty high. Only to date, as you're probably aware, there's only 300 national coverage determinations that have been done. And one of the thoughts was that the reason the ACA baked in the USPSTF to sort of create that pathway was to allow at least some evidence to start to inform what those national coverage determinations would be. So the first way to go is, one is welcome. I mean, anybody here, a private citizen, a Medicare beneficiary, can request that CMS perform an NCD for something like that. There's nothing that stops you. That's democracy in action. But as with everything else, it's super complicated and political. The second place you can go is do a LCD, do a local coverage determination. Those, if you think NCD is political, wait till you get into LCD. But you might succeed there because those are much more local areas. This is sort of the target for a lot of benefits that are sort of created at the local level, and then potentially those can bubble up a little bit higher. The third way is you could do a CMMI pilot and get it certified or actuarially certified for broader expansion. And in fact, with cardiac rehab, one of the things you're probably aware of is that the rehab is built into the mandatory acute myocardial infarction bundle. So it was actually added to it as part of that because it was highly underutilized. And the thought was that because ACA dollars would touch it, then expansion authority would apply to it in some way to sort of think about how we can make it more value-based as well.
I'll make just a last comment. And we talk about return to work, and I think that's a great measure. I think there's presentism, but also not all insurance is covered by employers. And so the individual component, how do you then create a value proposition for somebody who's buying insurance just for them and their employer is not? And wearing that group of population is extremely price sensitive, and it may be another argument that we haven't thought of yet.
And with that, I think we have run through our time. I'd like to thank our panelists for a great discussion.